The University of Calgary, located in the heart of southern Alberta, both acknowledges and pays tribute to the traditional territories of the peoples of Treaty 7, which include the Blackfoot Confederacy, comprised of the Siksika, the Piikani, and the Kainai First Nation, the Tsuut'ina First Nation, and the Stoney Nakoda. The City of Calgary is also home to Métis Nation within Alberta. So thanks for coming out to support our graduate students. So one of the things that we wanted to use the Wiki seminars for is to highlight our award winners. So as you know, Wiki offers graduate awards at both the master's level and the PhD level. And so today we are featuring our master's award winner and our PhD award winner. So we're going to have two talks, so each will be followed by 5 minutes of questions. So thanks for coming out to support these two graduate students. So I will introduce them one at a time. So first up, we have Jaiden Uppal. So he is a second-year master's student in the Cardiovascular and Respiratory Science Department, and he works under the supervision of Dr. Satish Rash. His research focuses on autonomic disorders, specifically POTS, which impacts females of childbearing age predominantly. And he's also conducting a crossover clinical trial for therapies for POTS patients. And the significance of that is that there are currently no approved medications to treat this syndrome. So looking forward to hearing about Jaiden's research.
Thank you. All right. Thanks for coming, everyone. Really appreciate it. So my thesis kind of looks over like the diagnostic implications and the pharmacological treatment of POTS, and I'll kind of break it down through 3 aims for you today. So I'll give a little background about me first, quickly. So this is me. I was born in Chilliwack, BC, which is a small town in British Columbia. It's turned recently into a smaller city, which is nice to see. I've always been fascinated with science, as you can see, and it's been the driving force where I am today. Over time, this love for science turned me into a science nerd with the main goal of becoming a doctor one day. I wish I knew what I was getting myself into. I was big into sports when I was younger. I played volleyball pretty competitively. I won a national championship, and I also did some rally driving when I was younger. I completed my undergraduate here at U of C in zoology. I also met some of my closest lifelong friends here. Shout out to the 8 a.m. geology labs. And then I joined the Autonomic Research Lab under Dr. Raj, where I completed a summer studentship, and I'm now at the tail end of my master's. So here's some of my lab team. This was taken a while ago, but couldn't have completed this journey without them and all their support. Okay, so I'll give a little brief background about what POTS is. So Postural Orthostatic Tachycardia syndrome, or POTS, is a disorder of the autonomic nervous system where we see an excessive tachycardia when transitioning to an upright posture or undergoing some type of orthostatic stress. So it's very chronic and debilitating form of orthostatic intolerance. It's estimated to affect 1 to 3 million people in the US. This stat was taken a while ago, so the prevalence is probably much higher now. And very importantly, 90% of POTS patients are actually female and of childbearing age. It is an underrecognized disorder with a quality of life comparable to those with chronic heart failure or chronic obstructive pulmonary disease. Okay, so for POTS diagnosis, we need to have an increase in heart rate of 30 beats per minute within 10 minutes of assuming an upright posture with no reduction in blood pressure, which is deemed as 20 over 10 millimeters of mercury. And there's chronic symptoms. So some of the symptoms include lightheadedness, shortness of breath, brain fog, difficulties with concentrating, fatigue, headache, insomnia, blurred vision, and a host more. So we can see here on the bottom right, the difference in heart rate between a POTS patient and a healthy control. So the heart rate continues to increase throughout the duration of tilt for the POTS patient, and reaches that 30 beats per minute threshold without a change in blood pressure, or a significant drop in blood pressure, rather. So my study aims to fill major gaps with regards to POTS treatment. There are currently no approved medicinal treatments for POTS. They're used on medications that are off-label. And there have been some studies investigating certain drugs on the heart rate control and symptom management here, but none have really compared the two common medications that are prescribed being ivabradine and propranolol, and I'll kind of break those down for you in a bit here. So, a little brief outline of my aim. So, aim one focuses on the differences in the hemodynamics between the head-up tilt and the active stand. So, two orthostatic challenges that we see for diagnostic or diagnosis. Aim two focuses on the crossover drug trial in which which medication actually improves heart rate, cognition, and quality of life the most. And aim three is my qualitative assessment of how patients perceive medications for POTS. So aim one here, you can scan the QR code if you want. We've just published this in Autonomic Neuroscience. So a little breakdown on how this works. So the active stand and head-up tilt tests are both used in the diagnosis of POTS. However, they are physiologically different in terms of how they work, and that could potentially lead to discrepancies in diagnostic prevalence. So the head-up tilt is a passive form of upright posture, not needing as much lower extremity muscle activation to remain upright, and as such, blood pools in the lower extremities, leading to reduced cardiac venous return, which leads to reduced stroke volume. And as a result, the body tries to compensate for the reduced cardiac output by increasing heart rate. Active stand is the active form of upright posture, requiring more lower body muscle activation to remain balanced. This uses the skeletal muscle pump system, increasing cardiac venous return, which allows for more stroke volume. And then we see a reduced compensatory heart rate increase compared to the head-up tilt. It still goes up, but not as much. So for our testing methods, patients first completed a 10-minute supine baseline, followed by a 10-minute active stand test. Then they completed another 10-minute supine baseline, followed by a 10-minute head-up tilt test. For the duration of testing, patients were connected to beat-to-beat recording equipment, which was recorded and analyzed. And then we used the minute-by-minute averages of those hemodynamics to compare. And then data were analyzed in this case with a two-way repeated measures ANOVA, Wilcoxon sign rank test, and McNemar's test. So here's just some of our demographics here. It was a retrospective study that we did on our POTS patient database or our AFT database. We have 63 patients that completed both the head-up tilt and the active stand. It is important to note that there was some baseline hemodynamic differences between the tilt and stand, specifically systolic and diastolic blood pressure was higher with the stand compared to the tilt. And here's the hemodynamic findings during the full 10 minutes of upright posture. So the blue is the stand, the red is the tilt. Here we can see in the highlighted box, the heart rate increased significantly more with the head-up tilt compared to the active stand, with no other major differences in the other hemodynamics between the two tests. And because of this, we see a discrepancy in the proportion of patients meeting POTS heart rate criteria, with more reaching criteria with head-up tilt compared to active stand. Again, this is a paired comparison. So what we decided to do is actually lower the heart rate threshold for the active stand to 27 beats per minute instead of 30. And we found that this actually reduced the discrepancy, but not to a significant extent. So some of the conclusions we drew from this were that the head-up tilt and active stand are validated tools to diagnose POTS. The heart rate differences stems from physiologically different mechanisms of action, which leads to the discrepancy that we see in the diagnostic prevalence. And that altering the heart rate thresholds of either the stand or the tilt can actually try and mitigate this discrepancy that we see. Okay, so my main aim that I want to talk about the most is the crossover drug trial. So background on some of the medications. So propranolol is a non-selective beta blocker or a beta 1 and beta 2 adrenergic receptor antagonist. There's a couple of receptors I'll talk about. So the first one being beta 1, which are located in the heart and kidneys. These are responsible for increasing sinus atrial node firing frequency to increase heart rate, increases atrioventricular node conduction, and increases heart contractility. In the kidneys, it's responsible for increasing renin release, which stimulates sodium and water reabsorption, increasing blood volume, and increasing blood pressure. Beta 2 receptors are located in more diverse or more spread out throughout the body, but most importantly in the bronchial and vascular smooth muscle, the liver, and the skeletal muscle. So usually when these are activated, we get bronchodilation, which is why those with asthma take salbutamol. It's a beta 2 agonist. And then vasodilation leading to reduced systemic vascular resistance to increase blood flow to the muscle. So obviously propranolol is reversing or inhibiting these regular effects. Ababardine is a funny channel blocker, which is also known as a hyperpolarization activated cyclic nucleotide gated channel located on the sinoatrial node myocytes. This is why it's called funny, because it's actually activated when it's hyperpolarized. So this channel actually allows for the inward flow of cations like sodium and potassium, which leads to the diastolic depolarization current, the pacemaker function. So that's actually that green curve you can see on the bottom there. So if we alter that slope, we can alter how long it takes to reach threshold, which then can change the firing frequency of those pacemaker cells, impacting heart rate. So ababardine actually lowers that slope, taking longer time to reach threshold, which means we have a reduced heart rate. And just a note, ababardine is already used mostly for inappropriate sinus tachycardia, so people with resting heart rates about 100 beats per minute when seizures are supine. So here's the design of our randomized double-blinded placebo-controlled crossover drug trial of these two active medications. Each patient completed a baseline visit, so visit 1, and was then randomized onto one of the study medications and took that medication for 28 days plus or minus 7 days for wiggle room. Then patients would complete a 24-hour Holter monitor recording, some quality of life surveys such as the MAPS, RAND36, Compass 31, OGS, and when they came in for their visit, they would complete a head-up tilt test. So patients underwent, between each phase, each patient underwent a 7-day washout period before starting the next randomized phase. We hypothesized that ababardine and propranolol would reduce orthostatic heart rate and symptoms compared to placebo. We included patients with a confirmed POTS diagnosis. They were aged 18 to 60 years old and were able to provide informed consent. Prior to testing, patients were connected to continuous hemodynamic monitoring equipment, including the Finapress Nova or the Windac data acquisition system with the NextFin. So this equipment, again, allowed us to record beat-to-beat hemodynamics of heart rate, systolic and diastolic blood pressure. For the analysis, we calculated the minute-by-minute averages of the hemodynamics, same thing we did for AIM-1, from the recorded beat-to-beat hemodynamics. So we did this to account for any noise in the signal. The highest minute average between 5 and 10 minutes of upright posture was deemed the peak 5 to 10 minute heart rate. Deltas were calculated from baseline values, and then we analyzed this using a linear mixed model, Wilcoxon sign rank test, and McNemar's tests. For the 24-hour Holter monitor, we used the Bitium Pharos device, which you see here, and our custom MATLAB software for the heart rate analysis. The 24-hour recording that we got was split into day, night, and the overall 24 hours. And then for each time window, we had a mean, max, and minimum value. So here are some of our demographics. We had a total of 40 enrollments with 28 participants fully completing the study. So we had 12 withdrawals. It's important to note that all participants in the study were female. So with the withdrawals, there was 3 that did not start, 4 withdrew due to personal reasons, and 4 withdrew due to adverse or serious adverse events, and we had 1 PI removal. And it's important to note that all study-related withdrawals were due to placebo, not the active study medications. Okay, so before I show some of the results, we decided to separate the analysis into 3 different comparisons. So ababardine versus placebo, propranolol versus placebo, and then ababardine versus propranolol. So here, I'm showing ababardine versus placebo first. Here's the linear mixed model data for the delta tilt hemodynamics of ababardine and placebo. I've included the baseline here in green just as a marker. We wasn't actually used in the analysis. So we can see here in the red box the heart rate in panel A. We can see clearly that ababardine is actually attenuating that heart rate response compared to the placebo. We see that there's a slight increase in systolic blood pressure for ababardine, same with the diastolic blood pressure. And then we see a slightly greater increase in systemic vascular resistance for ababardine as well. Going on to propranolol and placebo, again, we see that heart rate also attenuated with propranolol. We see systolic blood pressure increase with propranolol, and same with the diastolic blood pressure. And we see a decrease in stroke volume, but not to the same extent as placebo. Finally, we see the elevation in systemic vascular resistance, which makes sense because this is a beta-2 receptor blockage leading to vasoconstriction. And then the 2 active medications in the study being compared here, we see no really differences in heart rate, but it is important to note we saw a difference in an increase in systolic blood pressure, which is going to be important for clinicians when deciding which medication to use. In some cases, if, let's say, a patient has lower blood pressure naturally, this may be a better alternative to have ababardine instead of propranolol. Okay, so here's the peak heart rate analysis. So on the left, we have the absolute peak heart rate, and on the right, we have the delta. So we can see that there's a much higher peak heart rate with placebo compared to ivabradine, and we see a similar case with the delta. It's also important to note, ivabradine lowered the heart rate below pause heart rate criteria threshold. Same story with the propranolol, lower peak heart rate and lower delta, again, also below pause heart rate criteria. And then when comparing the two active study medications, peak heart rate's similar and the deltas are similar. So we're starting to see this pattern here. Here's the Holter monitor data. I've kind of put it in table format, but we can see that the mean and max heart rate for all 3 time windows was lower for ivabradine compared to the placebo. We also see this is a similar case with the propranolol compared to placebo. And again, following the trend, we're not seeing many differences between the active medications. We also collected some preference data from 22 patients that actually provided that data to us. From it, no one preferred placebo, 13 preferred the ivabradine, and 9 preferred the propranolol. Again, we break this down into our comparisons. We see obviously ivabradine is preferred over the placebo, propranolol is preferred over the placebo. And then here, interestingly, it's kind of split. We see a bit of a skew towards the ivabradine, but it looks to be that the patients actually enjoy medications, but they're kind of torn between which one. Important note. So, quick summary so far for this. We have ivabradine and propranolol lowering heart rate more than placebo. There's no major differences in the hemodynamics between the two active study medications, except for that systolic blood pressure. And there's a strong preference for the active study medications, but no preferential differences between ivabradine and propranolol themselves. So I'll get into some of the quality of life stuff now. So the first thing we looked at was the VOS, which is the Vanderbilt Orthostatic Symptom Score, which assesses 9 orthostatic symptoms, all rated out of 10. So 0 being absent, 10 being the worst. So on the left here, we have the full spectrum of the symptoms. Oh, sorry, this is the baseline. So while they're supine, this is the full spectrum. We see there's some differences in the shortness of breath. On the right's the total score. No real differences between any of the interventions. And then when we look at shortness of breath, we can see it's lower for both active medications compared to the placebo. Post-tilt, so this is after tilt is done. On the left, again, we have all the full spectrum. We are seeing some differences here in rapid heartbeat, tremulousness, and mental clouding. And on the right, we see that the total score is actually lower for propranolol compared to placebo. And then going into the specific symptoms, mental clouding was lower for propranolol compared to placebo. The rapid heart rate was lower for both active medications when compared to placebo, and tremulousness was lower for propranolol compared to placebo. So next we have the RAND 36, a 36-item questionnaire that measures overall health-related quality of life across 8 domains. So this includes physical functioning, pain management, emotional well-being, and social functioning. So on the left, we see significant differences in emotional well-being, pain management, and physical health composite score. And on the right, we have a higher physical health score for propranolol compared to placebo. On the left, emotional well-being was more improved with the propranolol compared to placebo, and then with pain, again, pain management was higher for propranolol compared to placebo. Compass 31 is a 31-item questionnaire that quantifies autonomic symptom severity across 6 domains, including orthostatic intolerance, vasomotor symptoms, secretomotor symptoms, gastrointestinal symptoms, bladder symptoms, and pupillar motor function. So on the left, again, spectrum, sorry, it looks kind of small on my screen, but we see some differences in orthostatic intolerance and vasomotor. And then looking at the total score, we see a lower overall score for propranolol that shows improvement compared to placebo. Looking at the orthostatic intolerance, we see it's more tolerable for ivabradine and propranolol compared to placebo. And on the right, we have less vasomotor symptoms with ivabradine compared to placebo. Then we have the orthostatic grading scale, which is a questionnaire that assesses the severity of orthostatic intolerance symptoms and their impact on daily activities. Again, on the left, we see differences in the frequency and severity of orthostatic symptoms. On the right, we have a lower total score for ivabradine compared to placebo, again, showing improvement. On the left, frequency was lower for both, and the severity was lower for ivabradine compared to placebo. And I think this is the last one for the symptoms, but we have the Malmo POTS symptom score, or the MAPS survey, which is a standardized questionnaire that evaluates the frequency and severity of prevalent POTS symptoms such as lightheadedness, palpitations, fatigue, and difficulty concentrating. This, we see muscle ache with a significant difference, and then on the right, there's no difference in total score. I do want to say we implemented this questionnaire in late, so there was about an N of 14. So it may be underpowered. But here's the muscle ache score was much lower for propranolol compared to placebo. So quick survey summary. I know there's a lot of graphs to look at, but ivabradine and propranolol seem to reduce symptoms compared to placebo. There's no major differences in the symptom burden between ivabradine and propranolol. And this is kind of similar to what we saw with hemodynamics. And going on to my last aim here, to get a greater holistic view, we decided to complete a qualitative interview study on patients who were taking medications strictly for POTS. So again, this was published as well, if you can take a look if you'd like. So we studied 13 patients with POTS who had or are taking medications strictly for their POTS diagnosis, and we conducted the interviews on Zoom, and they were audio recorded. The primary questions centered around the experience of POTS patients taking medications for their symptoms, and then secondary questions centered around the patient's subjective view on the benefits and downsides of the medication. Both questions were open-ended, and at the end, patients had an opportunity to speak on topics that were not brought up during the interview. And then transcripts were analyzed and themes were generated for conventional content analysis. So the main findings of this study: patients actually enjoy taking medications due to the benefits and can see themselves continuing their medications for the foreseeable future. Some of the benefits included symptom management, returning to regular life activities, increased energy, and overall improvement in quality of life. Didn't come without some downsides, which included having to remember the dosing schedule, the anxiety surrounding the lack of long-term data on these medications, and the side effects of taking the medications themselves. So we concluded that there was a need for greater priority on individualized care and an expanded access to effective therapies. So let's bring it all together here. We now know that medications do improve hemodynamics, specifically heart rate, in patients with POTS. We also know that patients actually prefer the active treatments over placebo, but there is individual variability in which medication each patient prefers. From the qualitative interview, we concluded that the pros outweigh the cons of medications, and patients are actually favorable to continue these medications for the foreseeable future. And from this, we provided evidence in favor of medication use in POTS. Individualized drug selection is essential to maximize patient outcomes. And this research, I think, is very impactful for POTS, as our research actually provides a holistic mixed method approach to support the treatment options for POTS, especially since there are no approved medications right now. So hopefully this research can go on to support approved POTS medications and improve insurance access to these medications, as they are quite costly. And I have heard from the interviews that individuals actually were, deterred from pursuing medications like ivabradine because of the expense. Sorry, guys, but thank you so much for listening. And I want to thank everyone part of my lab and all those that have helped me along this path. Thanks.
Yeah, good comprehensive master. Questions for Jaiden?
Yeah. So the patients were on medication for 28 days plus or minus 7 days. And they were to do the quality of life surveys and the Holter monitor recording at least a week before. So we sent them out through REDCap, and they were sent out a week before their scheduled visit. Thank you.
The two drugs that you tested, those are the most commonly prescribed off-label for these patients?
Not most common, but they're common.
Oh, okay.
Yeah, I think the most common right now is, actually, I might be wrong, but propranolol and midodrine's a big one as well. But these two are becoming more commonly prescribed. And so there have been single center trials and like case studies on the two medications. And we thought because it's becoming more popular to prescribe these, it would be probably more important, and especially in the POTS community, to do an efficacy assessment of these two compared to each other.
Right.
Yeah.
Okay. And one of your metrics for your quality of life was pain. So
Yeah.
what symptoms?
So I think pain would be for, I know a lot of people describe headache and migraines as one. Muscle aches are another big one that they complain about. I think generalized pain as well. A lot of these patients also have, comorbid conditions that they can also bring up as well, like EDS. And just like, yeah, generalized pain itself. Yeah. Yeah. So were there like, sorry, can you say that again? From what I understand, no. Usually for POTS diagnosis, the standard diagnostic criteria is the increase in heart rate, the blood pressure doesn't drop below 20/10, and then symptoms. They have to have chronic symptoms. So symptoms lasting longer than 3 months. And there's like a whole house of symptoms like the ones I stated. But between the two sexes, no, there's not. I don't think there's anything that's specific for one or the other right now. I know with long COVID, it's a bit different because the prevalence is a bit more mixed when it comes to male and female, but pot similar. Sorry. Yeah, sorry, I didn't want to take your thunder there. But with that one, it's a bit different. It's a good question. Right now, I don't think they understand why it's more female dominant. I know they're saying estrogen might be a factor with its cardioprotective properties and stuff, but from what I have also understand, the severity of POTS and also the prevalence of POTS begins to deteriorate as individuals age. So again, something to look into, but yeah, I don't know specifically. Yeah, so there for our studies, we usually have pregnancy or wanting to become pregnant as an exclusion criteria because it does influence cardiovascular parameters. I think there was something I was reading. There was a paper that came out recently that talked about pregnancy POTS and how um, females that actually give birth after the fact that didn't have POTS before now have POTS. So again, it could influence a lot of things. So to not have that influence in our study, we obviously excluded for that, but it is definitely an impact on hemodynamics for sure. I'd have to look, but I just know that at least the symptom, from what there was a trying to remember, but I'll have to look again. But from what I remember, the symptom burden that these patients had began to deteriorate over time. I don't know when exactly, like if there was an average time. Maybe Dr. Raj can answer that. Yeah. Sorry, adults.
Just the okay. Okay, so next up is the recipient of our PhD award. So this is Rashmin Hira, so a PhD student also working with Dr. Raj. Her research program aims to explore the function of the autonomic nervous system in long COVID. The autonomic nervous system controls the autonomic functions of our body, like heart rate and blood pressure. Impairment of heart rate or blood pressure can result in autonomic disorders, such as POTS. Long COVID resembles POTS when comparing symptoms such as lightheadedness or brain fog. So her research is required to explore the differences in long COVID versus POTS. So, Rashmin.
Thank you. So since Jaiden gave my talk already, I think we're done. I'm joking. Okay, so thank you everyone for coming. So like Dr. Thompson said, my talk is on assessment of autonomic nervous system regulation and recovery in long COVID. So as many of you know or are aware of, the COVID-19 pandemic had devastating effects all across the world. Until date, there have been 770 million recorded cases, as well as more than 7 million recorded deaths. And what we came to find out shortly after the rise of the pandemic was that a lot of patients weren't recovering after that initial COVID-19 infection. And what is long COVID? It's a condition in which symptoms that develop after a COVID-19 infection don't recover. They continue for 12 weeks or more, and that is a very small amount. We actually see that patients have this condition for years after. And symptoms include lightheadedness, brain fogs, shortness of breath, palpitations, etc., which sound very familiar based off of Jaiden's talk. So that is why a lot of literature started coming out looking into the similarities between long COVID and autonomic dysfunction. And a lot of papers did look into POTS specifically, so postural orthostatic tachycardia syndrome. And we also did publish on that, which is what I will be delving into today. Now, due to the similarities that were seen between long COVID and autonomic disorders, specifically POTS, the two objectives of my project include comparing autonomic function between long COVID patients and healthy volunteers, as well as assessing whether those autonomic deficits improve over time or whether they persist. So we'll get into the first one. The main thing that we wanted to do was conduct extensive autonomic function testing, because a lot of the studies that had been coming out looking into autonomic dysfunction in long COVID didn't actually conduct proper autonomic function testing. And that includes the active stand test or tilt table test. Now, in our study, we did implement the active stand test, and as Jaiden has eloquently described, that does lead to a lower heart rate response compared to the gold standard of the tilt table test. So it is possible that going into this study, we were expecting, I guess, underreporting of POTS. But that is a test that we used. And the other thing that we looked into were sex-based differences in POTS, or specifically long COVID, because there are sex differences in POTS. So like Jaiden already described, I feel like I'm going to be saying that a lot actually during the talk. But yeah, there is a high female predominance in postural orthostatic tachycardia syndrome. And because of the similarities between long COVID and POTS, we also wanted to look to see whether there was a skewed sex distribution in long COVID as well. Now, for the study, we included long COVID patients that were between 18 to 80 years old, male or female, and they had to have new symptoms that were lasting at least 3 months or 12 weeks, and they had to have a positive PCR test confirming that they did have a COVID-19 infection. The test that we did was the active stand test, which is a 10-minute supine baseline followed by a 10-minute stand, and we had beat-to-beat hemodynamics recorded throughout, including heart rate and blood pressure. We assessed different autonomic abnormalities or autonomic disorders. And the first one, so it's POTS. We also looked into IST, which is inappropriate sinus tachycardia, and that is an arresting heart rate or supine heart rate of more than 100 beats per minute. We looked into orthostatic hypotension, which is a drop in blood pressure of at least 20 millimeters of mercury within the first 3 minutes of standing and symptoms. And we also looked into initial orthostatic hypotension, which is a transient drop in blood pressure of at least 40 millimeters of mercury within the first 15 seconds of standing, and it is followed by recovery. So blood pressure does go back to baseline levels. And we had 70 patients with long COVID included in the study. And as you can see, we did have a high female predominance. So about 80% of our cohort were female. Their age was around 40s to 50s, so they were a middle-aged population. And at this time, they had had COVID-19 for more than a year they had had long COVID for more than a year after their initial COVID-19 infection. So when we looked into the prevalence of the different disorders in the group, we saw that there was a high prevalence. So about 72%, so about 3/4 of the group met the hemodynamic criteria for at least one of those autonomic disorders as described. And the highest was actually initial orthostatic hypotension. So about 61% of patients met that criteria. About 30% met POTS criteria. And we had about 2 patients that met OH criteria and 1 that met the IST criteria. Now, going back to the active stand versus tilt table testing, while I did say that we may have expected to underreport, this prevalence is actually what a lot of papers, even those that did tilt table testing, did find. So 30% matches other literature. Then we delved into male and female prevalence, so the differences between male and female patients. We saw that overall there were more female patients that met the hemodynamic criteria for at least one disorder. But when we looked at the different subgroups, IOH we actually saw similarly between the two groups, and POTS patients was predominantly female. And that is what we expect to see. But with IOH, we saw that that wasn't the case. And so there is a difference between whether it is long COVID is predominantly affecting female patients versus male patients. This was a spoiler alert, so I guess we didn't get that far into the presentation. Lastly, we also looked at hospitalizations. So we compared patients who were initially hospitalized during their COVID-19 infection versus those who are not, and we saw that the prevalence was not different between the two groups. And this suggests that regardless of the severity of the initial infection, it is possible to still develop that disorder. And so pre-existing comorbidities or the severity of the infection does not impact that. So now that we know that patients have a high prevalence of disorders, we've looked into sex differences, the next thing was to explore a little bit further for why that might be. So is it possible that the new onset autonomic disorders were due to underlying impaired autonomic function, whether sympathetic or parasympathetic? The way we looked into that was to look at the cardiac, vascular, and baroreflex autonomic function in long COVID. So we looked at heart rate variability, which is a quantitative measure of cardiac autonomic function. We looked at blood pressure variability, which is a quantitative measure of vascular autonomic function, and baroreflex sensitivity, which is a quantitative measure of heart rate control in response to changes in blood pressure. And these are all non-invasive measures that we implemented. So for this one, we had the same long COVID cohort, and we also had a healthy control cohort, which also was between 18 to 80 years old and had no confirmed case of COVID-19 or lasting symptoms after a COVID-19 infection. And participants with abnormal heart rhythms were not included for the purpose of this testing. We use the same stand test, so the 10-minute baseline followed by the 10-minute stand with beat to beat hemodynamics recorded throughout. And we calculated we calculated heart rate variability using time domain and fast Fourier transform. We obtained different measures of heart rate variability, such as RMSSD, that is a measure of cardiac parasympathetic activity. We use fast Fourier transform to measure both low frequency and high frequency for heart rate variability, which are cardiac sympathetic and cardiac parasympathetic tone measurements, respectively. And we looked at baroreflex sensitivity using cross-spectral analysis, and this is a measure of autonomic balance or heart rate control. And these data were also published last year. And so there will be a lot of figures here, but I'm just going to give you the overall view. When we compared between healthy controls and long COVID patients, we saw that long COVID patients had reduced upright, parasympathetic, and sympathetic tone. And when we looked at the different subgroups, so we did split the groups into their different hemodynamic criteria qualifications. So we had a group with long COVID POTS, we had a group with long COVID IOH, and we had a group that had no abnormalities. They did not meet any hemodynamic criteria for any disorder. And we compared them to controls. In that subgroup analysis, we found that there were different responses at different times. So while supine, it was a long COVID IOH group that actually showed more deficiencies. So they had reduced sympathetic and parasympathetic tone. And then while upright, it was actually the long COVID POTS group that showed more deficiencies or reductions in their parasympathetic and sympathetic tone. So overall, we're seeing that there are different responses based off of what subgroup that the patients are in, as well as what position they are in, whether supine or upright. And so just to quickly give you what the impact is of those measures. So reduced BRS is associated with increased risk of cardiac death. Reduced parasympathetic tone is associated with increased mortality and reduced survival. And reduced sympathetic activity can result in frequent dizziness or syncope or fainting episodes. I'd also like to emphasize the importance of methodology. So it was important to do the autonomic function testing in order to actually assess for the different disorders amongst long COVID patients, as well as actually look into the sympathetic and parasympathetic tone. And secondly, it was only because we did the active stand test that we were actually able to assess for IOH. With the passive tilt table test, IOH is not detectable as frequently. So it ended up being an added advantage to using the stand test for this study. So now that we know that long COVID patients have a high prevalence of disorders, we see that there is evidence of impaired parasympathetic and sympathetic activity. We wanted to look into recovery. Do the patients recover? So we wanted to compare patients over time. So what we did was after about a year or more, we brought patients back and did the same testing, which I'll describe once again in a little bit. And we did expect that patients might recover because now they were so far out from their initial COVID-19 infection that maybe their condition would resolve. So we did the same active stand test as I've described. We did the same heart rate variability, blood pressure variability, and baroreflex sensitivity measures. And we did have surveys at the 2 time points, the quality of life and symptoms, that we did have the patients complete. And for this one, the figures themselves are showing the comparisons between the patients at baseline and patients at follow-up. But main thing to take away is that there were 21 patients who completed the follow-up visits after their initial baseline visit. And they were predominantly female. And at this point, they were 2 years out on average from their baseline visit. So what we saw overall was that when we compared their hemodynamics, so supine or upright, systolic, diastolic blood pressure, and heart rate, we saw that they actually had higher supine and upright blood pressure in the follow-up visit. And this is more evident in the upright position, actually. And then when we looked at the heart rate variability, blood pressure variability, and baroreflex sensitivity measures while supine and upright, we saw that blood pressure variability, specifically low frequency blood pressure variability, was higher in the follow-up visit compared to the baseline. And low frequency blood pressure variability is a measure of sympathetic tone. And so it being higher indicates that there is higher sympathetic activity occurring in these patients while both supine and upright. And lastly, we looked at questionnaires, and I'm glad I don't have to explain them because Jaiden gave a quick overview while doing his talk, but we looked at Compass 31, which is that symptoms questionnaire, looking at those different domains. And then quality of life, around 36 looks at the health-related quality of life. Overall, no changes between the 2 time points. So in conclusion, we're seeing there's an increase in blood pressure, there's an increase in sympathetic activity, and no changes in quality of life or symptoms. So what we can deduct from that is that long COVID patients are not recovering over a long time, but they are changing, and that has to be looked into further. So the overall implications of the study, we saw that there is a high prevalence of different autonomic disorders amongst these patients. There is a high female predominance in POTS, but not in IOH, which indicated that there are different demographics involved in long COVID. There was evidence of autonomic impairment in long COVID, but between the subgroups, there were different types of autonomic impairments, which shows that long COVID is not a homogeneous group, and each individual group does need to be looked into differently, and different targeted treatments may be needed to be implemented. And lastly, we saw that patients are not recovering, but they might be changing. That does need to be looked into further, as in what does that imply? What does increased blood pressure, sympathetic tone indicate? But overall, it does indicate that because they are not recovering, they still do require treatment strategies. Further, we are currently looking into comparing long COVID POTS patients with non-COVID POTS patients, and we're also looking into whether a non-pharmacological intervention may impact and improve long COVID symptoms. So that includes increase in salt intake, but I don't have that data right now. So with that, I would like to thank you all for joining me today, and as well as my committee and lab members. Thank you. Yeah, so prior to the testing days, they were asked to stop any medications or hold any medications that were related to heart rate or blood pressure, because we wanted to see obviously how they respond to the testing without any interfering medications. But there aren't any specific long COVID medications because every single person has such different symptoms or manifestations of the condition, that it was mostly just heart rate, blood pressure related, like autonomic function related medications that we asked them to stop. Yeah. Yeah, so we do have that data, and we have done that analysis as well. So first, I would say 90 to 95% of the patients were vaccinated. Some were vaccinated after their initial infection, some were vaccinated before. Majority were vaccinated before they got the initial COVID-19 infection that led to their long COVID condition. And when we stratified, there were no differences between, but the N is very small of patients who were not vaccinated. Compared to those who were. So, but they didn't show a difference between prevalence or any of these other testing that we did. And then when we looked at number of vaccines, most had 2. So that again, the N is very small for people that had 3 or more at the time that we did the testing. And so that also didn't show any differences. But again, there's some statistical biases there. Yes. But we did also have patients that did have COVID-19, but no lasting symptoms. So they had to have had their infection more than 3 months prior and no lasting symptoms.
Okay.
Yeah. 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 Or they didn't know exactly. Yeah. So we did have a mixed group.
Yeah.
Yeah.